Hello and welcome. I'm Tanya Chamberlain from the Division of Anatomy at the University of Leeds, and in this video we will be taking a closer look at the brain. So what's coming up today? Well, we're going to take a closer look at the brainstem and introduce you to the cranial nerves, the majority of which come directly from the brainstem. We're also going to look at the cortex in closer detail, specifically the primary and association areas of motor and sensory cortices, and how damage to these areas can affect a patient. So let's go and have a look at the learning objectives for today. After this video and any necessary further study, you should be able to describe the origins and functions of the cranial nerves. Describe the areas of the cerebral cortex subserving the major special functions: motor, somatosensory, visual, auditory and language and social behaviour. Explain the manifestations of related disorders to the social behaviour cortices: visual, motor, somatosensory, and auditory and language. Right now, let's briefly introduce the cranial nerves and take a look at their roles throughout the body. The cranial nerves are a group of 12 paired nerves that, unlike the other nerves of the body, arise directly from the brain. The majority of these nerves act only in the head and neck region, but there is a special nerve that has multiple roles in the trunk. To see the cranial nerves, we need to move the brain into a better position. We are currently looking at the lateral aspect of the brain, but instead we need to look at the ventral surface. This can be thought of as the underside of the brain. This is where we can see the emergence of cranial nerves as they leave the cerebrum and the brainstem. As already mentioned, we have 12 pairs of cranial nerves. 10 of these 12 pairs arise from the brainstem. The first two that we will look at do not arise from the brainstem, but instead arise from the cerebrum. The cranial nerves are numbered 1 to 12, written in Roman numerals, but they also have names too. Knowing the names of the cranial nerves will help you remember the roles of each nerve. The first nerve, or cranial nerve 1, is the olfactory nerve. The olfactory nerve begins rostrally and is important for transmitting the special sense of smell dorsally to the brain, where it can be perceived. Sensory receptors in the nasal cavity bind with chemicals inhaled and fire action potentials. These synapses in the olfactory bulb demonstrated with this swelling, before transmitting the information dorsally into the olfactory tract. The optic nerve is cranial nerve 2. These nerves begin at the retina of the eye and carry the special sensory information of sight to the brain. As they travel dorsally, some of the fibres of these nerves cross over at a region called the optic chiasm before travelling back to the thalamus of the brain and then delivered to the appropriate cortex for processing imagery. Cranial nerve number 3 is the oculomotor nerve. This is the first of the nerves that emerges from the brainstem. The oculomotor nerve is a motor nerve that innervates 4 of the extraocular muscles of the eye. These muscles allow you to move your eyeballs independently of your head. We have another nerve that innervates the extraocular muscles of the eye. This is cranial nerve number 4, or the trochlear nerve. This motor nerve innervates the superior oblique muscle of the eye. Cranial nerve 5 is the trigeminal nerve. This is important for the sensory innervation of the face, nasal and oral cavity. It is also important because it carries motor fibres to the muscles of mastication. It is quite easy to spot as it arises from the pons and has a significantly large root compared to the other cranial nerves. It also has a large swelling immediately after the root called the trigeminal ganglion. This is where the cell bodies for sensory fibres of the trigeminal nerve are housed. Cranial nerve 6 is a motor nerve for the final extraocular muscle of the eye. This one is for the lateral rectus muscle of the eye. This muscle allows the eyes to abduct. It is for this reason that cranial nerve 6 is called the abducens nerve. Cranial nerve 7 is the facial nerve. The facial nerve innervates the muscles of facial expression. It also carries the special sensation of taste from the anterior 2/3 of the tongue. It also has some parasympathetic fibres in it. These are part of the autonomic nervous system, and these fibres travel to the salivary and lacrimal glands, and when required cause the secretion of saliva and tears respectively. Cranial nerve 8 is the vestibulocochlear nerve. This nerve is very important, as not only does it carry special sensation of hearing from the cochlear apparatus in the ear, but it also carries special sensory fibres from the vestibular apparatus in the ear. The vestibular apparatus is hugely important for balance and orientation, so if something goes wrong with this system, the patient can experience, in some cases, hugely debilitating vertigo and the nausea that comes with it. Cranial nerve 9 is the glossopharyngeal nerve. The glossopharyngeal nerve is the nerve that carries special sensory information of taste from the posterior 1/3 of the tongue. It is also a sensory nerve that detects touch within the pharynx. In short, the glossopharyngeal nerve is responsible for detecting stimulus that makes us gag. Cranial nerve 10 is the super important and frequently discussed vagus nerve. The vagus nerve has a huge number of roles in the body. This cranial nerve is the only one that operates outside of the head and neck. It takes on a huge role in the distribution of parasympathetic innervation to the heart and the foregut and midgut. This innervation is responsible for decreasing heart rate and promoting secretions and motility of the gut for digestion. Within the head and neck, the vagus nerve provides sensory innervation to the soft palate and motor fibres for the muscles of the soft palate. Cranial nerve 11 is a slightly controversial nerve. This is known as the accessory nerve, and its primary role is supplying motor innervation to the muscles of the neck. However, as stated, this is a controversial cranial nerve, as it does contain some spinal afferent nerves in it also. So, controversially, and new emerging information shows it also supplies some of the sensory innervation too. Though, as a cranial nerve, it is only considered motor only. As a cranial nerve that contains spinal component, it is a motor and sensory nerve. Cranial nerve 12 is the last of the cranial nerves, and this is the hypoglossal nerve. The hypoglossal nerve provides motor fibres to the intrinsic muscles of the tongue. These muscles allow for the protrusion of the tongue, and for those individuals who have the ability to roll their tongue, the hypoglossal nerve allows you to do that. So, after a brief overview of the cranial nerves, let's review what else forms our learning objectives for today. So now we can move on to cortical localisation, where we'll be looking at areas of the cortex associated with performing special functions, such as motor regions, general sensory regions, visual, language and behaviour areas of the cortex. Over many years of research, some ethical, some not so ethical, neuroscientists, doctors and psychiatrists have mapped the brain according to functions associated with each area. We know that the cortex of the brain contains grey matter, where neurons are able to synapse and information is able to be processed. The regions of the cortex that are much more consistent than we might originally think are called gyri and sulci. Every healthy brain has a fairly uniform selection of gyri and sulci, despite the many depictions of the brains you might have likely seen. These wiggles and squiggles of the brain are largely consistent from person to person. This uniformity has allowed scientists to identify and map regions of the brain associated with a particular function. The functional regions of the cortex can be roughly classified into 3 types. Firstly, we have the primary projection areas. The primary projection areas are where basic processing takes place. In the case of sensory pathways, this is where major pathways, or ascending pathways, terminate. So if you stub your toe, your sensory neurons will detect the stimulus, transmit this information by ascending up the spinal cord, and distribute this information to the primary sensory area of the cortex, where it is processed and determined to be painful. On the contrary, motor pathways begin in the primary projection area and descend. Let's assume you've lost your temper at stubbing your toe and decide to kick the table. The primary motor cortex first fires action potentials that descend down the spinal cord, where it synapses a motor neuron that travels out of your leg and instructs the muscles of your legs to contract and produce a kick. All of the information in the primary projection areas is quite basic or crude. It detected discomfort through the ascending pathway and performed a crude or basic movement via the descending motor pathway. All of the primary projection areas of the cortex are similarly basic. They are just for the receipt or distribution of information. The association areas of the cortex are more about finely tuning information from the primary projection areas. In the case of visual areas, while the primary projection areas will see the image, the visual association areas will help you understand that image. They help process things like orientation, recognizing images or shapes, or whether something looks familiar or a little strange. Likewise, the association areas of the general sensory areas will help distinguish between different types of stimulus. This might be like determining whether you are feeling cotton or a feather. Your primary projection area will feel something soft, and your finely tuned area will help you decide whether it's soft like cotton wool or soft like feather. The association areas of the cortex are larger than the primary projection areas, as more processing is required for the understanding the differences between crude action and discrete action. Lastly, there are some areas of the cortex that are dominant and some that are not. This is called the lateralization of dominance. What we mean by this is that some functions are largely dominated by one of the hemispheres. If you are right-handed, like 92% of the population, your left cerebral cortex is dominant for hand function. This is because all of the motor and sensory processing in the face and body is performed at the opposite side of the brain. This will be covered in further detail, so don't worry about it too much now. In order to map the functional regions of the cortex, we first need to address some basic landmarks. Let me bring you back to this image. On the left, we are looking at the lateral aspect of the brain. On the right, we are looking at the medial aspect of the brain, having removed the left hemisphere. Both of these brains belong to people that are looking to the left side of the screen. The rostral brain is on the left and the caudal aspect of the brain is on the right. These are easily remembered by looking for the cerebellum, as we know that this is located in the occipital region of the head. The first thing we should do is look at sulci and fissures of the brain. Fissures is just a fancy word for a very deep sulci. You can see that I've drawn on the important ones here. The first and probably most important landmark is a sulcus called the central sulcus. On the lateral aspect, the sulcus can be seen extending dorsally from the cerebrum, and when we look at the medial aspect, we can see this travels as far ventrally as the cingulate gyrus. The central sulcus marks the division where the frontal lobe becomes the parietal lobe, and this forms an important landmark for identifying a region of the cortex responsible for motor and sensory processing. The gyri located around this sulcus are named in reference to this sulcus. So the gyrus that lies in front of or rostrally to this sulcus is called the precentral gyrus. That's because it's the gyrus before the central sulcus. And the gyrus immediately behind or caudally to this sulcus is called the postcentral gyrus. This is because it's after the central sulcus. That's the beauty of anatomy. Most of the time the name makes perfect sense. So the cortex rostral to the central sulcus is the frontal lobe, and the cortex that lies caudal to the central sulcus is the parietal lobe. At the caudal border of the parietal lobe, we have another significant sulcus called the parieto-occipital sulcus. This sulcus does exactly what it says on the tin. It marks the boundary between the occipital lobe and the parietal lobe. It is much easier to see on the medial surface of the brain, but on the lateral surface it can be a little harder to identify. The occipital lobe is largely associated with visual perception. Within the occipital lobe there is a transverse sulcus called the calcarine sulcus. The calcarine sulcus is where images are seen by our retina and projected. It is only visible on the medial surface. Now then, for the first of our fissures or deep sulci, this one is the lateral fissure. Dorsal to the lateral fissure, we have the frontal lobe, and the central sulcus and the parietal lobe. Ventral to the lateral fissure is the temporal lobe. So the lateral fissure marks the boundaries between the frontal, parietal, and the temporal lobe. The temporal lobe is fundamental to auditory processing and the comprehension of written and spoken language. The last fissure is called the transverse fissure. This is a very deep fissure that runs between the cerebellum and the cerebrum. This fissure is very easy to spot at a quick glance from both the lateral and the medial views. Within the transverse fissure, we have some important structures like blood vessels and protective folds of dura, both of which will be discussed in a later video. Now we have located our important landmarks, let's go and begin breaking down the cortex into functional areas. Firstly, we will look at the primary motor area. The primary motor area is located on the precentral gyrus and is therefore found within the frontal lobe. This is where major descending pathways begin. These are motor pathways for the body, such as the corticospinal pathway, or for the face, as in the corticobulbar pathway. All of these descending pathways are termed contralateral. That means the left cerebral hemisphere controls the right side of the body, and the right cerebral hemisphere controls the left side of the body. You do not need to know why this happens, you just need to accept that this is what happens. Through extensive brain mapping, research and investigations, we have also been able to determine that there are different regions of this precentral gyrus that are allocated to different motor functions of the body. This means that the primary motor area and precentral gyrus is topographically arranged. Not only have we been able to determine that this is consistent from person to person, but we've also been able to see that there are different proportions of this cortex appropriated to each motor function too. On this coronal section, we can see different proportion and location of the motor fibres on the precentral gyrus. On the medial aspect, we have the foot and the leg, and as we move laterally, we can see the hip, trunk, shoulder, arm, elbow and wrist. Take note that when we reach the hand, fingers, face, lips, jaw and tongue, the proportion of the cortex dedicated to the motor functions in these regions is rather large. But that makes sense, doesn't it? These parts of the body are what we associate humans as having quite superior control over. We possess the ability to use fine motor skills of our fingers, and we can create a multitude of fine or micro gestures of our face. We have also developed vocal language, and therefore our tongue requires a great deal of control in order to clearly enunciate our words. An important take-home message from this is that the medial aspect of the primary motor area is dedicated to our lower limbs, and the rest is found on the lateral surface. Also, the proportion of cortex dedicated to each region is based on the demand of each region. Those regions performing highly skilled tasks require more neurons and therefore take up more space on the cortex. We've looked at the primary motor area. Remember, the primary projection areas are largely associated with very basic functions. We will now look at the association areas of cortex that are involved in finely tuning functions of the primary projection areas. The first one will be the association motor areas. Because these are involved in finely tuning primary motor areas, it makes perfect sense that they would be located near the primary motor areas, and in fact they are. The secondary motor area is located rostrally to the precentral sulcus. To make sure this is clear, the primary motor gyrus is located on the precentral gyrus. The secondary motor area is located on the gyrus in front of that, and it is only called the secondary motor area on the lateral surface of this gyrus. The secondary motor area is associated with organising patterns of movement. On the medial surface, we have a supplementary motor area. This is another association motor area, and it is found on the gyrus anterior to the precentral sulcus on the medial surface. This association motor area is known as the supplementary motor area, and it is involved in trunk support, finely tuning the trunk in responses to change in posture. Like with the primary motor areas, all the motor association areas are contralaterally innervated. So the left hemisphere controls the right side of the body and face, and vice versa. We've done primary and association motor areas. Now let's have a look at general sensory or somatosensory areas beginning in the primary somatosensory area. This can be found on the postcentral gyrus within the parietal lobe. This is the region where major sensory pathways terminate, whether that be from the body, such as the spinothalamic or DCML, or whether that be from the face as the trigeminothalamic pathway. Once again, they provide contralateral innervation, and once again they are topographically arranged. The topographic arrangement can be seen on this coronal section. This time we've done it for right hemisphere for the sake of balance, but both of these hemispheres, like with the motor, you would see a similar distribution pattern. Let's have a look at the distribution pattern. What do you notice? Yes, they are similar patterned to those seen in the motor cortex. We have the foot and the leg on the medial aspect. This time it's joined by the genitals. Then on the lateral aspect, we have a huge number of neurons dedicated to the fingers, face, palate and tongue in relation to the size of these areas on the body. It makes sense why this would be the case when you think about the significance of these areas. The hands are used to gauge the feel of something, and the face houses incredibly important structures such as the eyes, the opening to the respiratory and gastrointestinal tract. The tongue and palate help us to identify whether we have put something dangerous in our mouths, such as a fishbone or glass. The heightened perception of touch in these regions has developed over time to ensure that we are not damaging ourselves, so our cortices have proportioned more neurons to these areas as a survival mechanism. And it should be of no surprise to you that the association somatosensory areas are going to be located near to the primary somatosensory area. And here they are, found on the superior parietal lobe on the gyrus caudal to the postcentral sulcus. The association somatosensory areas receives input from the primary somatosensory area, and it is used to determine or interpret what we feel. It is the association somatosensory area that is used to identify whether we are stroking cotton wool or stroking a feather. This area receives the crude information from the primary projection areas and works out the minute details. Like the rest of the brain, it innervates the contralateral body and face. We've done the general motor and sensory areas, so now let's have a look at some more specialised areas. The first one is the primary visual area. As previously mentioned, the occipital lobe is associated with vision, so we can see this area in question. Specifically, the primary visual area is located on a stretch of cortex called the striate cortex, which is located around the calcarean sulcus. This is where we project images from the retina to. Like other areas, mapping of the brain has revealed that it is retinotropically arranged. This means that different areas of the retina are projected to different regions within the striate cortex. The focal point of our vision is the very centre superfocus part of the image that we are seeing, and this is projected most caudally at the occipital pole, whereas the periphery of our visual field is projected more rostrally. The visual association area is located in the pre-striate cortex. This, in similar fashion to the other association areas, is located around the primary area for visual processing, as it can be seen on the medial views on the cortex on the right. The association visual area of cortex finely tunes information from the primary visual area. It is responsible for discriminating shapes and images and processes the orientation of the input from the primary visual field. We have another slightly different visual association area. This one is called the frontal eye field. Interestingly, the frontal eye field is located nowhere near the primary visual area. Instead, it is located in the frontal lobe of the brain. Have a think about what we know about this area of the brain. We already know that the frontal lobe plays a significant role in motor function, and in fact, the frontal eye field is located just rostral to the premotor cortex. This visual association area is responsible for eye movement. Saccadic eye movement is the rapid unconscious eye movement made between two focus points, largely when visualising stationary objects such as words on a page or seated people in a room. The frontal eye field is also responsible for instigating voluntary movements of the eye, like when rolling them in exasperation. Let's have a look at the primary auditory area. This is found within the superior part of the temporal lobe in a gyrus known as Heschel's gyrus. Information from frequencies are projected onto Heschel's gyrus from the cochlea. Again, this region is arranged very specifically. Because the area is associated with sounds or frequencies, this area is called tonotopically arranged. The cochlea in the ear is wired to detect different frequencies of sound, and each of these areas have their own neuron which fires when that frequency is detected. Neurons that develop action potentials as a result of high frequencies synapse at the posteromedial part of Heschel's gyrus, and neurons that generate action potential as a result of stimulation from low frequencies synapse at the anterolateral part. What we mustn't forget is that humans are a highly evolved species of mammal. During our evolution, we have developed a complex verbal language. In addition to this, we have also developed written language representative of communication. Consequently, we have quite a large area of cortex dedicated to the processing and generation of sound, because our species depends on it for effective communication. Auditory association areas are the areas devoted to language. Firstly, we have an area called Wernicke's area. This can be seen on the lateral aspect of the superior temporal gyrus, slowly creeping into the parietal lobe. This is the area where we process verbal and written language when we see or hear it. If you like, it's not too dissimilar to having a built-in dictionary in thesaurus. Broca's area is different. Again, it is an auditory association area that is involved in language, but look where it's located. It is located in the anterior precentral gyrus, in the frontal lobe. We've met this a few times now, and we know that it plays a significant role for other motor functions, so have a think about the role that Broca's area might play in language. It is the motor production for speech. Now, the auditory association areas undergo lateralization of dominance. To remind us of what this means, it's that some functions are dominated by one hemisphere of the brain. With regards to the auditory association areas in the majority of the population, the left hemisphere is dominant for linguistic function. Therefore, in most people, damage to the left hemisphere often results in difficulties with language, or aphasia. How does this damage present? Well, damage to the auditory association areas can produce a few different types of aphasia depending on what area was damaged. Damage to Broca's area can produce Broca's aphasia. This is known as non-fluent aphasia. With Broca's aphasia, the individual has no difficulty in understanding language, but can experience a huge difficulty in generating speech.
So Clara, how did you get your injury?
Home. Dizzy. Lightheaded. Fall. Friend. Call 911.
In that video, we can see that the patient has difficulty creating sound and pushing words from their mouth. They are fully able to interpret what is being asked of them, but are struggling to articulate their words. This presents with long pauses, overphonation of some sounds and underphonation of others. Patients will often compensate for their difficulties by consciously eliminating words and speaking in very short phrases to communicate. Contrary to Broca's aphasia, if we were to damage Wernicke's area, we can experience Wernicke's aphasia. Take a look at this video.
Hi Byron, how are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. But they'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We
get to
will store it
Juneau.
right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment.
In that clip, we meet a patient with Wernicke's aphasia. With Wernicke's aphasia, there is no issue with the production of speech, but there is a processing dysfunction with the comprehension of language. This results in a patient who can speak fluently, but the words often don't make sense. It is also understood that the patient is unable to process the receipt of language, so they don't understand what is asked of them. To help you remember the difference between Broca's aphasia and Wernicke's aphasia, it can be useful to think that Broca's aphasia results in broken speech, and Wernicke's aphasia results in weird words. Those phrases should be avoided when communicating with patients. The prefrontal cortex is located, unsurprisingly, in the frontal lobe. It is found anterior to the primary motor area. We've already met this cortex when introducing association areas such as the frontal eye field and the premotor cortex, and more recently with Broca's area. The prefrontal cortex also forms significant circuits with other areas of the brain. These areas can be collectively called the limbic system. Collectively, the limbic system and prefrontal cortex play an important role in high-order functioning, like with behaviour, memory, and reasoning decisions. Our highly developed prefrontal cortex is what has allowed humans to develop social behaviours and decision-making skills that have accelerated our evolution into highly complex species. So that summarises the areas of the cortex associated with functionality. Let's go back and look at the learning objectives to see what is next. Now we need to have a look at how damage to each area can manifest, and to do that we'll have a look at some case studies. Our first case study is related to this person here. This person is famous in the history books of medicine and neuroscience. This is Phineas Gage, who lived between 1823 and 1860. Phineas Gage's story is one of the most fascinating and influential in the history of neuroscience. On September 13, 1848, Gage, a 25-year-old railroad construction foreman, was working near Cavendish, Vermont. Whilst using an iron tamping rod to pack explosives into a powder hole, the powder unexpectedly detonated. The 110 cm long, 3.5 cm rod was propelled upwards, entering Gage's left cheek, passing through his brain and exiting his skull before landing 24 metres away. Remarkably, Gage survived the accident and was able to speak and walk shortly afterwards. However, his recovery was not without complications. He developed an infection and spent several days in a semi-comatose state. Despite these challenges, Gage's physical health gradually improved, and he was able to leave the house within a month. The most profound impact of the accident was on Gage's personality and behaviour. Before the accident, Gage was described as a hard-working, responsible and well-liked individual. However, the damage to his frontal lobe resulted in significant changes. He became fitful, irreverent and prone to profanity, showing little respect for social norms and struggling to maintain his job. These changes were so pronounced that his friends and acquaintances remarked that he was no longer Gage. Gage's case provided early evidence of the role of the frontal lobe in personality and behaviour. His injury demonstrated that specific brain regions are responsible for particular functions, a concept known as cerebral localisation. This was groundbreaking realisation at the time, as the prevailing view was the brain functioned as a whole without specialised areas. Observations made by Dr. John Martin Harlow, who treated Gage, were crucial in documenting these changes. Harlow's detailed accounts of Gage's injury and subsequent behavioural alterations provided valuable insights into the relationship between brain damage and personality. This case became a cornerstone in the field of neurology and psychology, illustrating the importance of frontal lobe in regulating behavioural and social conduct. In the years following Gage's accident, Gage's story continues to influence scientific thought. His skull and the tamping iron were preserved and studied, contributing to our understanding of brain anatomy and function. Gage's case also highlighted the brain's remarkable ability to adapt and recover from injury, as he managed to live a relatively normal life for 12 years after the accident, despite the severe damage to his brain. Phineas Gage's story revolutionised our understanding of the brain by providing concrete evidence of the link between the brain structure and personality. It underscored the significance of the frontal lobe in governing behaviour and social interactions, paving the way for future research in neuroscience and psychology. Gage's case remains a seminal example of how brain injuries can profoundly affect an individual's personality and behaviour, shaping our knowledge of the brain's complex functions and capacity for recovery. So, case study 2. This patient comes into clinic with a complex medical history. He's undergoing cancer treatment and requires monitoring due to the effects of chemotherapy on a brain tumour. Unfortunately, his brain tumour has caused bilateral or both-sided blindness. Which cortical area, when damaged, could result in bilateral blindness? His CT scan reveals the location of his tumour. When reading a CT scan, orientation is important to establish when looking for abnormalities. This scan is a transverse or axial view. What that means is we have taken horizontal slices through the body, and in this case, the head. The top of this image is the face, so it's anterior, and the bottom of the picture is the back of the head, or posterior. We also need to bear in mind that CTs are read from the feet end of the body. So here we have our left and right in place. This large red arrow is pointing to an abnormality. It's pointing to the patient's tumour. Given what we can work out from the orientation, which of the region of the cortex is damaged? This is the occipital lobe. Our final case study is that of patient 3. This 67-year-old patient is sat in clinic when she suddenly becomes unwell. Thankfully, a diligent member of the team stops and rushes over to help when it is noticed that the patient is slumped over in the chair. The admin team spots the patient's face drooping and immediately raises the alarm. The patient is clearly unwell. When asked, she struggles to respond and her words are hard to understand because her speech is so broken. The team recognise that this is probably a stroke and ask the patient to raise her arms. She can only do so with her left arm. She blurts, "numb," when being asked to raise her right arm. Given all this information, which areas of cortex have likely been impaired by this suspected stroke? Okay, so we need to break this down. This is not as simple as first glance and there's a lot going on. This patient has had a cerebral infarction. In other words, areas of her cerebrum have died as a result of a lack of oxygen. She can't raise her right arm. We know that motor pathways originate in the primary cortex. This also accounts for the face. The right side of her face is also drooping. This means that something has happened in the primary motor cortex, so it can't innervate the muscles of the face. So we know that the damage is to the primary motor cortex of the face. We also know that the primary motor cortex innervates contralaterally. Therefore, if the right arm and right face are paralysed, it must be the left primary cortex that is damaged. If we look at this widely publicised poster, we can see that these are recognised symptoms of a stroke. The patient complains of a numb right arm. The primary somatosensory cortex is responsible for the perception of sensory information. Again, the primary somatosensory cortex innervates contralaterally. So if the right arm is numb in the event of a cortical stroke, it must be the left primary somatosensory cortex that has been compromised. What is particularly interesting to note is that the left primary motor cortex and left primary somatosensory cortex share a blood supply. We also know that this patient has had difficulty speaking. More specifically, she struggles with the motor production of words. We know that the motor production of words is located in Broca's area. What else do we know about Broca's area? We know that in most of the population, the left hemisphere is dominant for linguistic function. So currently, all of our signs are posting to a left primary motor area stroke and left Broca's area stroke. And in fact, this is most likely. What you don't know yet is that the primary motor area, the primary somatosensory area, and Broca's area all share a main blood supply. So when the main artery going from the left hemisphere gets blocked, both of these Broca's area, the primary somatosensory cortex, and the primary motor cortex, suffer the effects of the occlusion, which is another reason why these are the common signs of a stroke, and it is therefore awareness campaigns like this that highlight the importance of acting fast. Face, arms, speech, and the importance of time. And that brings us to the end of our case studies. At the end of this video, you should now be able to describe the origins, the functions of the cranial nerves. Describe the areas of cerebral cortex subserving major special functions: motor, somatosensory, visual, auditory and language, and social behaviours. Explain the manifestations of related disorders to the social behavioural cortical areas, visual, motor, somatosensory, and auditory and language.